Hello everyone, we have today Professor Gerard Conway, who is a lead consultant in reproductive medicine at UCLH London, and I'm going to discuss a few common issues which come to our mind when we take into consideration the adolescent polycystic ovaries, hirsutism and the thyroid issues in our fertility work. Jerry, it's going to be a little mix of apple and oranges, the questions which you're going to discuss. And what I would like to start on adolescent women, adolescent girls who come with polycystic ovaries. Because you basically look into those endocrinological issues. So how do you come to a diagnosis of PCO? What problems you face in diagnosing a polycystic ovary in adolescent?
I think in adolescence it's particularly difficult and often under-recognized that a lot of the normal features of adolescence, such as acne, irregular periods that take a little longer than average to become monthly, these are common parts of adolescence. In addition, many girls are gaining weight in adolescence, and all of these features can be normal processes, but if they are found to have polycystic ovaries on ultrasound, then often they'll acquire the label of PCOS. Now, clearly, if a woman with, or a girl with irregular periods becomes regular, then goes irregular again as she gains weight, then it's more likely she's PCOS. But I think the caution has to be in the younger ones where they've never had a time of normality, and you can't be quite sure, is that polycystic ovary syndrome or is that normal variation? So my main theme there is not to make the diagnosis too early.
So what age, do you set an age cutoff or you differ by patient to patient?
It depends a little bit on the period pattern. So if your periods become regular quite quickly, within a year, and then stay regular, say, through your 14th and 15th year, but then become irregular, then it's quite easy to make the diagnosis at 60. But if they're always irregular and you've got acne, I would wait and try and postpone making a diagnosis. And it's perfectly safe to wait for a year, sometimes even 2 years before being so. Now, if the symptoms warrant it, there's no reason why you couldn't offer treatment, particularly for acne, which gets quite a lot better on the birth control pill, and the irregular periods. If they would like to have acne treated and more regular periods as a preference, then they could be treated with the oral contraceptive pill. But I would wait before I made a label, strict diagnosis until a little later.
Till later. So a girl comes anything between 15 to 16 years of age with irregular cycles. I think we should more put emphasis on just counseling with the irregular cycles if she's not bleeding heavily, or should we just try and go to OC pills in this particular group?
It's very much personal preference. There's no medical risk in this group until they go to the phase of oligoamenorrhea of less than 4 periods per year. Then particularly the obese ones are at risk of endometrial hyperplasia. So those are unsafe to watch, or you need to be careful about those. But for normal weight and 60-day cycle, there's no risk. And so there's no reason why you couldn't continue to watch them. There's no medical benefit to treatment at all. It's all based on personal preference.
And we do have an overlap between the PCO and the milder variety of congenital adrenal hyperplasias.
Yeah.
And in India, we see a lot of lean polycystic ovaries and it's always a dilemma with such a low BMI of maybe 16 and 17 to diagnose a polycystic ovary, or are we looking at an hypothalamic amenorrhea in that particular age? So what would be the distinguishing investigations which you suggest, a battery of tests, which could help us guide through, and how important it is to make a difference? Is it necessary to go into these details?
It's often argued at this point, how aggressively should you seek out mild, non-classical CAH? That's mainly going to be in the woman who has quite prominent androgen symptoms of hirsutism or acne, possibly also with oligomenorrhea. My practice is not to pursue the diagnosis aggressively. There's quite a big overlap between the 17-hydroxyprogesterone measurement, which is the biochemical marker, from women with polycystic ovaries and women with very mild non-classical CAH. So even that test is not perfect at making a distinction. And then you have to think, well, is my management going to change if I reclassify this woman to having non-classical CAH? Well, in the first instance, probably not. I would avoid using steroid as a treatment in adolescence and even sometimes later on in life. I would still wish to choose a oral contraceptive pill probably and an anti-androgen because I think it's a safer, healthier
So it
option.
wouldn't make much difference.
So it doesn't change management.
So management would remain the same. And when it comes being a fertility consultant, when these girls with adolescent endocrinological issues come to us with irregular cycles especially, we tend to investigate them from a fertility point of view. I don't know why, but when we get biased and probably just looking for a diagnosis, hunting the diagnosis of polycystic ovary, we start doing AMH levels.
Yeah.
So should we rely on that as we rely on the reproductive age group who are chasing fertility, or should we do it, or should we just not?
Well,
So from the diagnostic point of view, AMH will not contribute.
Well, it's one of those ones you have to interpret cautiously. It's valuable if it's high, because only PCOS does that. But it's not helpful if it's normal or even low, because it may be that it's yet to come up.
Yeah. And even PCOS has a wider range of AMH to say,
Yeah.
Depending upon the phenotype of the PCOS,
Yes.
such as XS, so that would go through. Another issue in adolescent is the hirsutism, and girls are extremely sensitive to the kind of hair pattern they have, and they would go for treatments. So, as we understand it, metformin is no cure for hirsutism. But where does metformin stay as far as the adolescent irregular cycles are concerned?
Metformin has a minor benefit. It reduces your circulating insulin by 20 or 30%. And that is a benefit. That will reduce testosterone slightly. The trouble is that the effect is too modest. And so any benefit for hair growth is going to be slow and not usually effective enough that a woman would think it's really, really useful treatment. So I would often use it in an overweight person with irregular periods as part of the program thinking to the future. But, and you can combine it with the birth control pill. And so one can be looking after the metabolism.
Yeah, many times they are associated with the same gastric side effects.
So you can be thinking of your metformin as your sort of slow burn. It's there to hopefully minimize weight gain as the teenager grows older. But for the short-term benefit, using a birth control pill plus or minus an anti-androgen. I have a few times I use 3 treatments concurrently at the outset for a teenager. And this is on the basis that there are strong impressions from PCOS specialists that if you hit quite hard as a teenager, you reduce the impact of PCOS later on. That applies particularly to the birth control.
So as a gynecologist, I think it's in India it's our responsibility to pick up the PCOS and start managing them early.
I think
get an opportunity to do that, and so that they have a better progress in the future, as a fertility outcome may also be
The
better.
studies are difficult to do because you would need a 10-year follow-up to be certain of it. But it's a strong impression from all clinics working with adolescents that if you treat with the birth control pill through adolescence, you have less of a phenotype later. And I've certainly seen, I don't know whether you have in your practice, teenage girls who started the birth control pill early, really well controlled, relatively few symptoms, suited them very well, and then they stop when they want to start their family. And out comes the metabolic syndrome, and it all becomes uncontrollable. I don't know what the mechanism there is.
Well, I think a lot of girls at that age in the Western world could be taking OC pills for birth control as well.
Yes.
So you would be seeing a lot of girls that way. We don't see it that often, so we want to know.
Sometimes it's only treatment for hirsutism.
So how long one should take OC pills? Like 3 years, 4 years, or 5 years? Like they're starting at maybe about 17 years if they're starting. How long they should go on the OC pills? Or
if they're relatively low risk for thrombosis, that's number one risk. So at every year I would do a thrombosis risk profile, like their blood pressure, their weight, and have they any other thrombosis family history. If there's nothing on the thrombosis risk factors, then there's no reason why you couldn't continue indefinitely. There's certainly no data, which is a common internet myth, that it would affect future fertility. A lot of girls think it might, and mothers do. No data, so I think that's absolutely clear. And then there is some data of really prolonged use, so 10 years plus, which is not uncommon. You do risk run a slightly higher risk of breast cancer.
Okay.
That prolonged higher exposure to supraphysiological estrogen is a very slight excess risk. It's very small. It may be one case per 100,000 or per 1,000 in life, but I do counsel them for very long-term use.
And just sticking on to the hirsutism, what distinguishes you to take a call whether you'll go on ocipils or spironolactone, or at what juncture we should introduce the second drug?
It is very individual. I think there are some mothers and daughters who really would like to avoid the birth control pill. Okay. And then you have a good option with perhaps metformin and spironolactone. Metformin to give more regular periods, and spironolactone. Head-to-head studies, spironolactone and the OCP are very similar in their effectiveness. So that is a good way of doing it. Or you could use spironolactone with cyclical Provera to control periods.
Okay.
You just have to do it separately. And so it's very much on how they perceive their risk and benefit of the OCP.
And where does Vanica stand here, the N-fluorothene cream?
Well, I'm a fan of Vanica in the young age group because if a girl has become very sensitive to her hirsutism, and if she's having unfriendly comments made by her friends at school, then it is the fastest acting agent is Vanica. You get your peak action in 10 weeks. Well, your peak action with birth control pill or spironolactone is more like 10 months.
So how long do you put your patients onto Vanica or to spironolactone? For how long would you?
Well, I would often start Vanica right away with your systemic treatment.
Okay.
And then overlap it. So they might use the Vanica for 3 months. That is its peak action or plus. And then by then you'd hope the systemic treatment is beginning to have its effect. That's an arbitrary time, so anywhere between 3 and 6 months.
And when it comes to monitoring the progress of the treatment, when it comes to hirsutism, is it that we depend on the clinical criteria, or we would go by some hormonal evaluations again and again to know where you are?
Yes, it's rare that I find I need to do hormones as we go. The birth control pill has a confusing effect on testosterone. The SHBG goes up, but the testosterone goes down. So sometimes the total measurement doesn't change. Spironolactone doesn't affect it much because it's an antagonist rather than affecting secretion. So I don't find the biochemical monitoring very helpful. I go totally clinically.
So what clinical parameters? We'll be doing a Ferman-Galway scoring every time, or you just cover the history of number of cosmetic visits?
Yes,
or the sparseness of hair?
I use cosmetic visits, whether they're using electrolysis or waxing, or in some cases laser. Is the frequency and intensity getting less?
Acne are pretty obvious anyway.
Yeah. And acne, you have other tools, such as you can combine with antibiotics, or you can combine with topical retinoids. So you can lessen the amount of systemic treatment. But this is where you almost, if you're working in a PCOS clinic, you almost have to become a part-time dermatologist because you can factor them all in together.